Welcome to the Mamatoosa podcast. It's so good to see you. My guest today is Dr. Kirsten Thompson, who is a board certified psychiatrist. She has a private practice here in Los Angeles, California, and is also founder of Remedy Psychiatry, which is an online platform for seeking psychiatric help and medication management for people who live in Los Angeles. And I'm so excited to have you. Thank you for making the time.
Thanks. Thanks for having me.
Of course. And you hold a very, very special place in my heart. Tell me how we know each other.
So you hold, an immensely special place in my heart for all three of my children. So we met at the Bradley birthing class, which I took when I was pregnant with my first child. And it was an all-natural birthing class, meaning a class where you would learn how women can give birth without pain medication and a lot of sort of medical interventions. And you were my teacher. And so during that class, which was 12 weeks long?
12 weeks long.
Yeah, quite
Every
a class.
Monday night for 12 weeks.
That's when I had some time on my hands before kids.
I think you were still a resident.
Yeah.
It was in your last year of residency.
I
remember
was
watching you go through residency very, very pregnant. And thinking, this woman's a superstar.
Yeah.
It's not easy. It's not for the faint of heart, for sure.
No, it was a thing. It was a thing, but it was good to learn. It was so different than my medical education at the time, learning about natural things, that it was really a necessary thing for me to learn the full spectrum of childbirth. And since you were my teacher, I think what happened, and remind me of the details, I think a little bit of like pregnancy amnesia, but I think you mentioned that you were a doula.
Yes.
And so we asked you to be our doula when we were done with the class. And you said yes.
Such an honor. It was absolutely an honor. I actually remember that I was in San Francisco. Oh my gosh, it's all coming back to me. I was in San Francisco when you were going into labor. I had 2 days off call and you called me and you were like, we need to do this. And I was flying back that night. And it all worked out. I was actually at a meeting with Penny Simkin, rest her soul, who is really the founder of DONA, one of the founders of DONA and the doula movement as we know it, the professionalization of doula work. Penny passed away just a little while ago, and I just went to a memorial for her. It's almost like a full circle because I remember it so well when we spoke. I think I was at Pike Place in Seattle, and I'm just coming back from Seattle where we did that tribute. Tell me, why as a physician would you enroll in a 12-week Bradley unmedicated vaginal birth class?
Well, I think there are sort of two reasons.
Yeah.
Like one, as an individual, I really like learning and sort of learning as much as possible. And that ties into the second reason, which is in medical school and training, we learn about a lot of the medical interventions, but we don't learn about sort of the natural interventions. And so when it came to medical school and then doing the OBGYN rotations, I think I remember we did 6 weeks of OBGYN in medical school to train. We certainly delivered a lot of babies vaginally and helped with a lot of C-sections. And, did a lot of the hospital-based interventions, which are mostly medication. So I knew that side of it. I knew what a C-section was and what would happen if I had one. But I'd never really thought about this idea of a sort of natural birth at home. And I started to hear about people having their kids at home. And I wasn't set on that, having a home birth, but I wanted to know kind of what the other end of the spectrum is. So C-sections on one end, major medical intervention. And then what is the sort of opposite of that, which felt like it was Bradley, where we watched videos, I remember from it looked like the 1960s or 70s of women
those videos were
in
old.
South America, birthing children while standing up. And it was so different than everything I had seen.
Birth in the squatting position.
Yes.
I used to show the OG one of that, which now is all over Instagram very easily. But back then, those videos were hard to come by.
Yeah.
And very powerful. And for some people, a little eerie to watch. And your partner was on board.
Yeah. I think as the one carrying the baby myself, he was sort of trying to be supportive and, do what was most helpful to me to feel empowered and ready for whatever would sort of come my way. And I liked that exposure of this is what natural birth is. I know what a C-section was. And for me, I think it was important to kind of know I'm going to try to do whatever is kind of safest when that day comes, but I want to know all the options available to me and know them well.
Right. And that's when you can have informed choice, is when the options are presented clearly and objectively, and you get to know which one suits your fancy or which one makes more sense to you. And it's a commitment, right? Bradley classes are 3 hours long for 12 weeks. So 12 Mondays in a row, you showed up with your husband. And I loved that my families who came always made it like a special night for themselves. So whether they were partnered or not, it was like the one time of the week where they focused on this baby, which for a lot of people in our busy lives, it was like, yes, I'm pregnant. I go to the doctor. I come back. I do my life. But this 3 hours every week was devoted to that. And you rocked your labor. Can you talk a little bit about your first birth if you're comfortable?
Sure. I mean, I don't know if
What
I
a labor.
rocked it so much as I was just like subject to the birth.
She rocked it,
that was
y'all.
happening
She
inside
rocked
of me.
it.
I don't know how much you control. It feels like you have no control over that. But and it's funny, you were in a different city at the time, which just shows you, and you were still there for the birth, which shows you that it was like a multi-day process, which again, I was in no control over, but I was at, I think one of the final routine visits at 37 weeks maybe, and my blood pressure was really high. And so I was diagnosed with preeclampsia, which is very disappointing because I was thinking about birth, but I wasn't thinking about all of a sudden me being, I knew what it was, but I wasn't thinking, oh, now my health is at risk and this other thing is at play. And they said you have to be induced and, you can go home and grab your bag and then come back to the hospital. So we went home. I think we went to In-N-Out because I was like, this is the last meal I'm going to have for a while. Possibly days. And we went back to the hospital and then they started sort of monitoring my blood pressure, which was kind of going up. And so then they began this like induction process, which was a series of like starts and stops. Yeah, I think you came partly into it. They sort of
I think it was when we had first started the first induction tool.
Yeah.
And I think I came like straight from the airport. I think I came from the airport, had dinner, changed, and came over. And so for the listener, preeclampsia is a metabolic condition of pregnancy where blood pressure begins to rise. People start retaining water. So we start seeing a lot more edema in the face, in the hands, and the feet. Not just the edema of like, oh, I'm pregnant and I can't wear my ring, but definitely more swelling, spilling protein into the urine because the kidneys are not really able to do their job in keeping the protein where they're supposed to be. So we see this seeping out of fluid from the blood vessels called third spacing. And the only cure for preeclampsia is delivery. There is no like, I had preeclampsia and then it went away. It went away because you got the baby out and got the placenta out and your body sort of had a reset. Now, interestingly, you didn't have preeclampsia for your other deliveries.
No.
So it's more likely to happen in first pregnancies. So preeclampsia is more a function of the first pregnancy. It can happen with subsequent, but we always look out for it with first pregnancies. And also you're in residency. So there's a lot of toll on the body. It's a first pregnancy and your blood pressure started to go up. So you were also on magnesium, which makes people feel like crap.
Yeah.
Magnesium is not an easy thing to take through the IV. Do you remember some of your symptoms? Yeah. I have pictures.
Yeah. I was like I had blurry vision, which made me so dizzy and nauseous that I was just wearing an eye mask, which was so weird to be like pregnant with my eye mask and, not being able to see anything. And that was really, really hard. Just the nausea. I think I was vomiting like repeatedly. Like as if birth wasn't enough. So. Yeah.
And just so my listeners know, you had a completely unmedicated vaginal birth with preeclampsia on mag sulfate IV, which later the nurse who was actually studying to be a midwife. Do you remember her? Your first nurse? She was incredible. And she was going to midwifery school, but she said that they actually never ever see that. She said the majority of people who are induced for preeclampsia on MAG do not have an unmedicated vaginal birth. You were a very, very like special statistic and people came to like see who you are because you were sort of the superstar on the ward on that day. What do you think allowed that to happen?
Well, I mean, I think it wasn't all fully planned that way. I think I was sort of telling myself if I don't need pain medication and another intervention that I was going to proceed. But the point at which I think we had a safe word. So the point at which I said the safe word meant like, give me the pain meds.
I'm done. Yeah.
I'm done. I remember saying it at some point. And since I was like a doctor already. I remember saying to you, like, I think I'm ready. Will someone please put in the order for pain medication? And I think you said, like, no, you're there. I was sort of like fully dilated.
Fully dilated.
And it was like that uncomfortable feeling when you like needed to start pushing. And I remember thinking like, oh no, it was a little too late. And you said like push. And so it sort of happened, but I wouldn't say that I was like hell bent on being unmedicated the whole time. That would sort of not be accurate. I was sort of going to go and make the best of it type of situation. But by the time I sort of wanted the pain medication, it was almost over anyway, luckily.
Which is usually when people who want unmedicated childbirth begin to ask for medication is at that tail end, where literally the emotional signpost is, I can't do this anymore. Get me out of here. Here's my code word. Here's whatever else you need. Put it in. And that's the point where we're like, all right, like you're like there, you were there, or you're almost there. But the value of the code word is pretty amazing. And then you went on to have 2 other completely unmedicated births, this time with no preeclampsia. What was your experience the second and third time having your babies?
It was just so fast. So the first one was that sort of prolonged needing to be induced, and then the induction was stopped, and then the induction was started again with a different medication, and then it was sort of slowed and started again. So it was a start and stop multi-day experience for the first one. Yeah. And then the second one, I think I was like in very light labor overnight, and I woke up and my water kind of broke, and I got ready to go to the hospital, and the baby was born an hour after I left home. So
we labored on, I remember you on all fours on your porch.
Yeah.
And at the time you were living very close to the hospital.
Yes.
So I remember we got there, and we always talk about this, but they were sort of like dilly-dallying. And I was like, no. She's going to have a baby. Like, she delivers very quickly. Yes. And they were like, yeah, okay, whatever. And then I was like, screw it. I'm going to drop the doctor word. I was like, she's a doctor at this hospital. And all of a sudden, everything like moved faster, and we went through like a back freight elevator.
Yes, actually,
do you remember?
Yes. Yeah, not to like scare people who are considering birth at all. But yeah, I remember I was like yelling, and it was like the hospital I worked at, which was slightly, you would think, embarrassing, but I didn't care. Like at one point I just was crawling on the floor, and then they were like, she needs a gurney. So they took me out of the wheelchair because I had climbed out of it. It was so uncomfortable to be sitting.
Of course,
that I was just
right there.
I was just on the floor in the hospital that I worked at, and then they got a gurney and put me on. And I think I was like yelling because it was so painful.
And
sort
you were
of already
like you were ready to deliver when you got into that room. But I just remember as soon as I was like, she's one of yours, it just sort of shifted everything, which I thought was so funny. I tried that the third time and it didn't work.
No.
The third time I was like, she's a physician at this hospital.
And they were like, we don't care. I'm sorry.
Someone turned around. The doctor or the nurse was like, we don't play favorites here. And I was like, okay.
Noted.
Fair enough.
That's good.
So it was faster. It was easier.
Yeah, actually, I think, my third baby was an hour. This baby was, I think, born 9 minutes after I left
This baby was
home.
born like within 15 minutes after we left the house.
Yeah,
like he was
so fast.
in your birth canal, I think, while you were sitting on that wheelchair, which was why it was so uncomfortable.
Yeah, it felt very dramatic at the time. But I was also glad it was over so quickly, because that's the beautiful thing about a fast labor.
You're not supposed to take that that's not something you can do for 2 days, for sure. So you and I have stayed in touch this whole time, and you have actually helped me tremendously. And I'll share the story of a client that I had who was experiencing severe postpartum depression and thoughts of self-harm. And I went to her house for the postpartum visit, and I was like, what do I do with someone who might harm themselves with 3 children? If I call 911, they might come and take her away and put her on a hold, separate her from her children. Is she going to hurt herself? Is there someone else at home? What can I do? And I called you in a panic, and you picked up the phone, and I was like, oh, thank God. I have a psychiatrist on the phone who specializes in postpartum mood and anxiety disorder. And you walked me all the way through what to do, which I've actually used before. I've used it, and I've used it again since then. Thank God it doesn't happen very often. But the first time as a midwife, I was like, what? Because as a doula, your scope is different than as the primary midwife, who's actually the person who caught that baby and it has the full scope to do everything. So thank you for that. I really, really, cherish the fact that you picked up the phone and gave me your time and guided me. But your specialty is postpartum mood and anxiety disorder. That's what most of your practice is based on. And I have about 4 million questions for you. First of all, there's so much stigma. There's shame. There's ignorance, not in the way of like, oh, you're so ignorant, but just in the way of people just don't know the spectrum of things that can happen emotionally and psychologically during the postpartum period, whether it's baby blues, although I've heard now we're starting to move away from that word, but baby blues that can sort of be a normal fluctuation in mood that should go away within that 2-week to 3-week mark, all the way to anxiety, obsessive compulsive disorder, intrusive thoughts, repetitive thoughts, suicidal ideation, psychosis. So the spectrum is very, very wide. And I think for a long time, we just focused on postpartum depression or what people call postpartum. Oh, she has postpartum, which drives me insane. If you had a baby, you have postpartum. It's called a postpartum period, not postpartum as a word. What are you seeing out in the field? By the time people come to you, first, how do they find you? And second, what are you seeing in terms of how people are being screened and how they're being directed to where they need to be, which by the time they come to you, they're needing medication and therapy, I'm assuming.
Yeah, well, I think things are changing, which is good. So I trained at the UCLA Women's Life Center, which is a clinic dedicated to women's mental health. And so we did most of our work was around postpartum depression, but also all the mood disorders that have to do with female hormones, of which there are many, like PMDD, perimenopause, menopause. So at the time, it was like a separate clinic at UCLA that you had to be referred to. Since then, it's great in that UCLA has kind of embedded a mental health aspect with psychiatry within OBGYN so that women get help sooner and with more ease, because that's a problem across our country as far as access to mental health care. Now I've left the UCLA bubble, although I still volunteer train some doctors as mentees of mine. But I have a private practice, Thompson Psychiatry, where I see patients myself, men and women, but many of them of whom have postpartum depression, OCD, et cetera. And then I have a telehealth company, Remedy Psychiatry, where we see patients in California for all mental health disorders, including postpartum depression and the other illnesses. And typically, to answer your question, how do people know they need help and get care? It's hard. A lot of women don't. Right. And they suffer in silence. And I know this because oftentimes someone will have their second child. And at that point, they kind of know what it's like to have one. Right. And they realize it's so hard. And they'll sort of start to get help. And then they look back on their first pregnancy and they say, oh my God, I was depressed or I was anxious and I just didn't even know it. And everyone was like, it's hard. It's hard. There's a lot of validation that being a new mom is hard, but not a lot of inquiry as to how hard is it? Do you need more help? What's really going on inside your head, even if everything looks perfect on the outside? And I think that's the battle that a lot of women are still fighting, which is there's this whole internal world of postpartum depression that nobody else often sees. So many of my patients, have postpartum depression, but they have things like recurrent intrusive thoughts or visions. So it's not like a hallucination that they think is real, but they'll have a thought come into their head or an image of something horrible happening to their baby. It's not something they want to happen or that is happening, but it's basically a fear in the form of an image. And it's terrifying, but yet they're experiencing this totally alone while taking care of their baby. And that's kind of one of many of the symptoms. But I use that one because it's a very solitary experience, right? And a lot of times women are home, taking care of the baby without other adults to even talk to, let alone say is this normal that I just had this vision? So it's a really tough time for a lot of reasons, but I think mostly because of the isolation that happens in the postpartum, in our country at least.
So that happened to me. I was sitting on the rocking chair with my second baby, I think it was, and I literally thought, what happens if I walk up to the banister and I drop the baby? And I kept seeing it. I kept seeing myself do it. I wasn't going to do it. I wasn't afraid that I was going to do it. But I was like, why am I even having this? This is awful. Didn't tell anyone because I was like, they're going to come and take my kids away if I tell anyone that that's happening. And by the grace of God, it went away. It sort of subsided over time. I had tremendous postpartum anxiety and depression with my first one. And I think with the second one, it was better. With the third one, it was definitely better. But by then I had like discovered therapy and tools and a program, you know, all these things. By the way, that horrible statistic, when we talk about the reasons why women die in the postpartum period, this is such a terrible statistic. And I think I've shared it before on the podcast, but the second reason is suicide. The first reason is they're killed by homicide, which I had never known until I read the research on intimate partner violence. People are killed during that postpartum period. I think because of the toll of having a baby, also on the partner, and on whatever underlying stuff was going on socioeconomically, emotionally, addiction, poverty, whatever is going on in that family, the toll of a baby exacerbates it. That broke my heart. Yeah. Absolutely broke my heart.
Well, and I think we're shedding more light on women's mental health in the postpartum, you know, as each year passes, but we still have a long way to go with men. And so the estimates are that about 10% of men have postpartum depression. So, and it's often manifesting as irritability and anger. So that sort of ties into that statistic of homicide in the postpartum year, because it is hard, right? People aren't sleeping. Mom may be depressed. They may be taxed on resources and money and help. But then on top of it, dad may be depressed. Right. And often men also don't get access to healthcare, and people are not screening men right now, routinely, at least, for postpartum depression in the year after birth. So all those factors combined make it a really tough and potentially risky scenario.
Because you think about postpartum hemorrhage, or I always think of something physical, like blood pressure skyrocketing and the person seizing, but homicide and suicide, it's mind-boggling for the United States. What about medication? There's so much stigma about, is it okay to take medicine? Is it not okay to take medicine? Is there a drug that is 100% safe?
No. Right. And that's true for all drugs, including over-the-counter medications. Yeah. So I think that's a good place to start the conversation with medication. And the tough thing about this is that every woman is different. So when I'm talking to each woman, we're not just saying like, should you be on a medication or not? We're talking about what is your illness, like your depression like. And you always have to be measuring, or I tell my patients, we want to be measuring the risk of your illness compared to the risk of medication and not ignoring one. So for example, many people feel like, oh God, I can't be on medication, so I'm just going to go off all my antidepressants because I'm afraid of the risk of medication. Well, the question is then, for this woman, what's the risk of illness? And if she's had severe anxiety where she's not eating and she loses 25 pounds and she's not sleeping, those are really poor elements for building a healthy baby. Or at worst, if she becomes suicidal when she's depressed and she goes off medication, then the risk of her illness is loss of life and abortion. And I've had patients, people focus a lot on depression, but I've had patients with such severe anxiety who get pregnant. I had a patient who had a very wanted pregnancy, like IVF, transfer, had to go to a different country. It was a so desired pregnancy when her anxiety was controlled, but she became pregnant and she went off all of her anxiety medications and became so convinced that she was going to be a terrible mother that she ended up having an abortion, elective abortion, when she was off medications because of the anxiety. And then got treated again and realized or reflected that that was a mistake because it was a very wanted pregnancy. So we always need to be thinking about what are her risk factors when she's ill? And then what are the risk factors for medications during pregnancy? And as it relates to that, we now have decades and decades of research on the SSRIs, at least like Prozac and Zoloft is the one we use most often typically, that they're generally pretty safe. Now, there's a lot of details there and tiny risk factors here and there that every woman needs to be aware of and consider. But we always want to be doing that versus the risk of her becoming very, very ill, which typically happens when people go off medication suddenly.
Right. So why Zoloft versus Wellbutrin or Prozac or Lexapro?
So it's a complex question because I wish I could say that we have tons of research in our country on men and women and exposures to women during pregnancy, but we don't, because to enroll women in studies, they need to sort of give permission to be taking a medication, and women don't want to put their babies at risk for any medication just to test it out. So all of our studies have some degree typically of confounding by indication, meaning the data is based on women who are depressed and need medication. And so for those women who have pretty significant depression or anxiety or OCD, and then they go on SSRIs, we have now a lot of information on the SSRIs in pregnancy. We have less on some of the other medications, although we do have some on Wellbutrin, and I've had women who have done great on Wellbutrin and they stay on it during pregnancy. But in general, the most research we have is on the SSRIs, and they are effective for many women. So that's kind of why, in general, women end up being on the SSRIs or have historically in the last, 10 to 30 years.
The other mind-blowing part of this is, how do you chase this ever-moving target of hormones, both in pregnancy and the postpartum period, that are so subtle and so nuanced that one hormone going up and down can change not only the chemistry, but the metabolism of the drug? Talk me through someone who, for example, has had a history. Let's just take a pretend case study. This person has some adverse childhood experiences. So maybe they saw violence as a child, or emigrated, or they were abused, whatever the childhood experiences is. And they've always had low-lying anxiety. And at some point in pregnancy, they decide, I need some help. They get some therapy. It's not enough. They now need medication. Is there an ideal time to start medication in pregnancy?
The short answer is there isn't. But what I would say is, having frequent checkups with a doctor or mental health care professional is kind of ideal because of those changing hormones. Right. So the best case scenario is if a woman can plan pregnancy and they think about it in advance, like, oh, I am going to want to get pregnant, and right now I'm on, these medications, X, Y, and Z. And then they come to me or their psychiatrist or their doctor and they say, I want to get pregnant. Is this safe? And we go through all the information. I remember at one point had like a 22-year-old, and she was so proactive. She was like, I don't even have a partner, but I just want to know and be educated on the risks and benefits of my medication and pregnancy, which is great. Wow. But with, 50% of pregnancies unplanned, right. It's, that's not the case for most people, I would say, or for half sure. At least. So ideally, women who can plan a little bit want to be educated about their medications, the risks and benefits, and then kind of stay on medication and get frequent follow-up or checkups during pregnancy to see if their medications need to be adjusted while the hormones are kind of going crazy. Because some women do get more depressed or more anxious, and some women are great and they feel the best they've ever had or ever felt in their life. So the frequent follow-up with a medical or mental health professional is kind of the most important thing to me. And when you do that and have regular visits, when the symptoms start to become impairing. And that's generally when someone may want to consider going on a medication or increasing the dose. So if someone's all of a sudden not sleeping at all, right, and they're not getting any rest, or their appetite falls off and they're not gaining weight like they're supposed to be able to build a healthy baby, those are the factors when it's worth considering that risk-benefit analysis of medication.
And define frequently.
Generally, every month or so. That's what I recommend for most of my patients if things are pretty stable. And that's because the hormones are changing so much and the body is changing so much. And often if women have like a weekly therapist that they are lucky enough to be seeing, that's good because then you have that sort of weekly cadence checkpoint.
Right.
And the therapist and psychiatrist can ideally be working together as a team so someone can let someone know, which is how I like to work with patients. And then we're all on the same page trying to support mom.
By the way, postpartum mood anxiety disorder, I read that can happen anytime between conception and 3 years after the baby is born, which who knew? It was always thought of as like that first 6-week postpartum transitional thing. 3 years is a long time. So are you finding that people can stay on the first dose, on that same dose all the way through and it works? Or do they often need more? Or do they need another medication that will augment?
Yeah. So every woman is different.
Right.
You know, as much as we would like to have like generalized medicine, the ideal is a personalized approach because some women are fine and they can stay on the same dose and they don't have recurrence of symptoms and they're kind of stable in pregnancy and the postpartum. And then some women really do need changes in their dosages, whether it's going up during pregnancy when the blood volume increases and there may be some degree of like a dilutional effect to their medication, or their symptoms get worse. They need those medications added, augmentation, or like meaning a second medication to be added. So everyone's sort of different in that regard. And I've seen it go both ways.
I remember I had a client who developed severe anxiety after a cesarean section, and I went to visit her at home, and she was not okay. Absolutely not okay. No self-harm or anything like that, but just so anxious. And I had the obstetrician's phone number and I called him directly and he immediately prescribed something. Kirsten, she was better within like a week. It worked so fast.
Yeah.
Was that placebo or does it actually work that quickly?
So the SSRIs generally take a few weeks to work on average. So that's why a full trial is considered 6 weeks, but hopefully, and many people do start feeling better in the first couple of weeks, 2 or 3 weeks, but not immediately. The newer medication, zuranolone, which is an allosteric modulator, meaning it's sort of, and it's a synthetic version of a neurohormone or brain hormone that we have as women that drops off after birth naturally. It's sort of on this hormonal cliff.
Oh, so it's not just estrogen.
No. And so zuranolone is a synthetic version of that hormone that drops off the cliff. That miraculously, and it's new-ish. There was an IV form a couple of years ago, and more recently in the last 2 years, there's a pill form, which makes it more available to people. And women with that medication start to feel better typically in 3 days. And I've used it many times at this point. It's only 2 weeks of the pill, and women take it for 14 days. And the research shows this as well. Often women start to feel better within just a couple of days if it works and they're tolerating it without side effects. And then the effects last. So it is possible for some women to feel better within a couple of days if properly treated.
And we can't forget placebo also. Perhaps just being seen and heard and taken care of already had an effect on how she felt. But I was like, wow, she's a different person.
Yeah.
Different within a week.
Yeah.
Completely different person.
Really wonderful. Women.
Which is a testament to a couple things. One is midwifery home visits.
Yeah.
Which we visit people on hour 24 to 48. And then we visit people again between day 5 and day 7. And then again at week 2. And at week 1.5 if we need. So we see a lot. And so do doulas, by the way. Doulas are postpartum doulas, and even your birth doula that's doing a postpartum visit or two see so much that falls through the medical system, especially for people who are in big medical systems, who they don't really even know their doctor. They went somewhere, they had a baby, they came home. They may never, ever go back for a 6-week checkup. It's really the doula or the family member or the sister or the neighbor that's like, hey, you haven't eaten for a few days, or you haven't showered, or you don't want to hold the baby, or, they start to get a warning that something is going on and can let someone know, but also speaks to collaboration between healthcare workers, where I had this OB's phone number and he picked up on the first ring. He's like, hey, what's up? I'm like, your client's not doing so well. And he immediately stepped in. I've had the opposite where I've tried to get hold of obstetricians to tell them something's going on with their client, and it's a big group and things are a little bit busy and a little bit possibly disorganized. Zero. I got zero communication back from the OB. And so I had to start looking for other resources. But how beautiful if we could have this for me, collaboration is always where it's at, whether it's between DONA, midwife, doula, midwife, psychiatrist, doctor. Bring the bridges together. It's the bridges that bring everyone together that makes birth safe for our people, because people are dying.
Yeah.
People are dying. This is not just, I feel a little uncomfortable. And becoming a parent is already so difficult. It's one of the most difficult things we do. And then all of this information on a little device that tells us how we should be doing it and how it should look, I don't actually think is necessarily helping. And so I always tell people, pick 2 trusted sources. One person you follow, maybe one healthcare provider, and then one friend who knows you, who really knows you, so that you're working within the parameters of you, not every person who's ever had a baby. Because I'm finding more and more, I'm getting moms who have a whole checklist of things they have to do, which is stressful to begin with. But then when things don't go according to plan, they don't fare very well because they had planned so well for it.
Yeah.
And childbirth and the postpartum period are really not anything you can guarantee what's going to happen. We can have an idea of, okay, I'm now getting really good at, when I see certain things in pregnancy, I start sort of screening for what I think could happen in the postpartum period, which includes if I see a family struggling during the prenatal visit. I'm like, okay, well, if we're struggling during a prenatal visit, then let's have a conversation about the labor, the birth, the postpartum period. Who's coming in to help?
Yeah.
So it's a lot. It's a lot for one healthcare provider to keep track of. And I can see how OBs in busy systems they're just doing their best to just keep up with the client load, which is one patient every 7 to 10 minutes. Is there any medication that you absolutely, in terms of psychiatry, cannot take when you're pregnant or breastfeeding?
Well, there are certain medications that do have, associated birth defects that are larger. So we generally stay away from some of those medications.
What's an example?
So Depakote or valproic acid is a mood stabilizer that can be associated with spinal cord abnormalities and more severe birth defects. So it is important for women of reproductive age who are on psychiatric medications or medications of any kind, right, with any doctor, to be aware of, if I get pregnant, are there birth defects from this medication? Just like, this is
on any medication,
yes,
really.
Acne medication is as well, for example.
For sure, yeah.
So, but more and more, I would say the opposite, where we're realizing that a lot of the medications we use are probably safe in pregnancy and probably have been. It's just that we don't have a lot of data on them. So there's a big study ongoing at Harvard around a lot of the antipsychotic medications, which we use for psychosis, but also bipolar disorder and depression augmentation. And more, we're actually seeing that they're safe in pregnancy. And so again, if you go back to that idea that, an unstable, unhealthy mom is a risk factor in and of itself to have a healthy baby, we do need to be having the discussion all the time for each woman, and what are your medications and what are your symptoms and what's best for the baby and you. Because as I tell my moms when I'm seeing them, we need a healthy mother to have a healthy baby, right? You can't have not a healthy mother and have a healthy baby. So we, on some level, have to put mom first and then consider the risks and benefits of medication.
Is every medication that's safe for pregnancy safe for breastfeeding and vice versa?
So breastfeeding, I would say, because most medications in the blood when a woman is pregnant kind of go into the baby at the same dosage in pregnancy, when it turns to breast milk and breastfeeding, the amount of medication is usually like a teeny fraction, less than 10% of what the dose would have been in pregnancy.
Right.
So on some level, the risk is much lower in breastfeeding. There are certain medications that we still try to avoid having a big exposure to in breastfeeding for other reasons. For example, most of the data we have on ADHD medications, the stimulants, suggests that at prescribed dosages for women with severe ADHD, we think they're relatively safe during pregnancy. But in pregnancy, the baby's in the womb and they're getting all their nutrients and food through the umbilical cord, so they don't need to be hungry and like cry for food. Now, when the baby is born and they're breastfeeding or formula feeding, well, if they're breastfeeding and they're getting some of that stimulant in the breast milk, it can have the side effect that it can have in adults, which is appetite suppression. Wow. So if the baby is drinking breast milk that has, Adderall in it, for example, or Ritalin, there's this theoretical risk that the baby's appetite could be lower and that they could cry or wake to feed less and therefore fall off their growth curve. And I've had this happen. So this is where, that risk-benefit analysis and getting frequent medical care is really important, because some women, I had a patient with multiple children with severe ADHD, to the extent that, getting in a car accident every day was a risk. So if you're driving around your 5 kids and you're pregnant, you need to take your medication or do what's required to be able to be a safe driver of those 5 kids. And so if you're pregnant, the baby's going to be exposed. And that was actually fine. The baby was born very, very healthy. And then she started breastfeeding and she needed to stay on that medication because of the aforementioned reasons, because her ADHD symptoms were so very severe.
Yeah.
And the baby sort of did start to fall off the growth curve. But with her pediatrician and I working together and her being fully aware of all these risks and benefits, we made significant modifications, which meant that she couldn't drive at certain times, but she was going to reduce kind of her medication dose to get the baby back on the growth curve. So that takes, so that's
It took a village.
Yeah, it takes a village. It's a very nuanced, individualized approach to that mom and her symptoms. And it did take a lot of coordination, but the baby's now very healthy and it was fine, but it took a lot of coordination and just being on top of things. Her being on top of things, most importantly, but also her medical team.
I think the statistic is still true that the number one prescriber for women of antidepressants is their OB-GYN.
That makes sense.
Not a psychiatrist. How do you feel about that? And what are some of the ramifications that you're seeing of that?
Well, I think it's bad insofar as it would be wonderful if everyone in our country had access to not only an OBGYN, but a psychiatrist. So someone who is trained only on mental health, just for more specialized medical care, right? But it's good in that OBGYNs are trained to recognize postpartum depression and are that first line, so they can hopefully see and evaluate and diagnose and treat someone right at that 6-week visit. So I think it goes both ways, but they are so taxed as it is. So I think the ideal situation is if they're working with psychiatry or, psychiatric nurse practitioners or psychiatrists, and they have easy, fast access. So I think another problem is, an OB can get a medication started, but then the mom doesn't know where, and, less than half the counties in our country have psychiatrists. So it's just very hard to find that specialized care.
Wait, say that again.
It's less than 50% of the counties in the United States have like a dedicated psychiatrist or access to care. So this is, there are a lot of areas. We think living in the big cities that everyone has access to care, but mental health, there's still an extreme shortage in certain parts of our country. And so not having that and that sort of extra level of medical care means if mom doesn't do well on the first medication or the symptoms don't get better quickly, then they have to go and find care. And that's really, really hard when you're depressed and you've got a new baby. I mean, it's impossible to get out of the door. So to find a psychiatrist when the first medication hasn't worked is really hard.
I had a woman on the show early on, actually, who suffered from tremendous postpartum anxiety and depression. And she talks about being in the throes of symptoms. And she and her husband had printed the list of psychiatrists that were within network. She said out of like 35 on the list, 3 were actually relevant. Mm-hmm. Some had moved, some had died. Some went into thinness, like it was like, where'd they go? And out of those 3, 1 returned her phone call.
Yeah, it's so hard. Yeah.
It's dangerous. It's really, really dangerous. But the downside of the OB prescribing is that OB can prescribe at 6 weeks, or some OBs are now seeing clients at 2 weeks, which is great. But often clients don't go back to the gyne for a whole year. So what happens in between that time, and is the dose the person needed at that 6-week visit going to be the same as 9 months or 12 months down the line?
Yeah. And I've seen patients like that are started on a very, very low dose right after postpartum. And then whether they didn't go back or they couldn't get an appointment or whatever the case is, I'll see them a year later and they've gone through a year of suffering on like a minuscule dose of medication that is not treating their symptoms. And they're just white knuckling it. And we're not even talking about the babies here, right? Because if mom is depressed or anxious, the baby is not getting the proper neurodevelopment from seeing mom's face and smiling and interactions and marked mirroring. So mom is suffering for that year, but the baby is also suffering developmentally if they don't have a present, healthy mom. So that is one of the gaps in healthcare. That's why I started this second company that takes insurance and is over telehealth and has soon appointments, is because I do think we all need and should have access to timely mental health care. And while not everybody needs medication, it does help a lot of people, and it would be better if the systems were in place where it was easy to get that second appointment 2 weeks after you start the medication, because you might have side effects. You might have stopped it.
Oh, 1,000,000%. And tell me about Remedy. I've sent people to Remedy and it's really fantastic. Tell me a little bit about it.
Yeah, so it's a telehealth company in California right now. And so we see patients all remotely over video. And the whole reason I started it was that everywhere I had worked previously, whether it was in a private practice, seeing, very successful Los Angelinos for cash pay, or whether it was me seeing people at UCLA who had insurance, or people in volunteer positions that had no money or no insurance, everybody really wanted personalized care where they could get an appointment tomorrow if they needed to, because they had more symptoms or side effects. And nobody wants to or should have to spend thousands of dollars or $600 for one appointment. So I made my private cash pay practice much, much tinier and essentially almost closed it. And then I opened Remedy about 5 years ago to really provide that access to care. And I had seen patients over video, especially in the postpartum, right? Mom can't come into the office easily. So seeing people over telehealth makes it much easier for patients and more cost effective. They're not paying for LA real estate to come see me. They can see me or see us over video. So, and we talk about sort of mental health care, because just like in the postpartum, diet, movement, sleep, those are all probably the most critical parts of our mental health. And that's what I always talk about with moms as well. But sometimes even beyond therapy and community, people do need medication, or they need something. And medication is one tool that we can try. And often people do feel much, much better. And they say they feel like themselves again. And that's a win for the mom, but also for the baby and the rest of the family if there are other kids.
And reason number 4 billion that you are one of those sparkly people in my life. You and I am just so humbled by the work that you do. You and your husband, both of you, really are changing the world one person at a time. Why do children who are born to mothers who are on SSRIs sometimes having lower APGAR scores?
So that's a good question, and I don't know the answer of that. So I was actually reviewing the data, and there is a teeny reduction in the APGAR scores, and it may have something to do with this neonatal adaptive syndrome. So moms who are on SSRIs during pregnancy, about a third of them have babies who then have this neonatal adaptive syndrome, we call it. And it sounds pretty bad, but it's essentially these temporary symptoms. Can be like a slightly weaker cry or sort of different superficial symptoms, I would call them. Nothing huge, like no neurodevelopmental changes or differences in organs or vital signs. And they resolve. And we don't really know what that is. It may be that the mom had the baby on medication, and then once they're born, the baby's no longer getting that medication. So it may be the baby's body getting used to being off medication, essentially.
But that quickly, though?
Well,
like in that first few seconds of birth.
No, you're right. You're right. That is not probably accurate. So I don't know. I mean, enlighten me if you know. I saw that there's this tiny difference.
Uptick, yeah.
But I don't know if it's totally causation or correlation with regard to medication or not.
It's so interesting because in our practice, first of all, I saw it when I was a doula in the hospital or a doula in home births. I mostly did hospital work as a doula, but the babies who were born to moms who were on Lexapro or Prozac or Zoloft, they just take a second longer to come in. Gotcha. They just take that they're just a little less tone, takes them a minute to take that breath. Nothing that requires a resuscitation, but definitely a team that gathers around the baby. Now, it's interestingly in the home birth model or in birth centers where we do water birth babies also take a minute to come around. So
even if they're not on
SSRI. So sometimes look, the baby would come around. It was a water birth. We knew that the mom was on SSRI and it was like, oh, okay. Now, which one is this? What are we working with? But either way, the babies come around within that first minute. So we might reach for we start with the stimulation. We might reach for the bag and mask valve, but typically they come around. But I never understood why, because SSRIs are not a depressant. So if the mom is on like a Valium or a central nervous system depressant or even alcohol, right? Yeah. Then you would see that makes sense. But on SSRI, which is really the serotonin that we're working with, why would that happen right away? It's a conundrum for me, but maybe more research.
Yeah. I mean, I have the short answer is I don't know, but theoretically SSRIs do or can reduce like panic symptoms in adults. That's why we use them for people with panic attacks and panic disorders. Yeah. And so even though they work predominantly on serotonin, they do work on some of the other neurotransmitters to a certain extent, like norepinephrine and epinephrine. So maybe it's something where they're sort of slightly reducing that response of, epinephrine, norepinephrine in a new baby that says like breathe and scream and cry. Yeah. I don't know, but it's so interesting. I'm not clear.
More to be revealed, huh? Do you know any research on CBD and THC use in pregnancy and the postpartum period in terms of psychiatry?
So the research that I'm aware of is, unfortunately, it's not good. So cannabis during pregnancy has more and more research coming out about potential long-term neurodevelopmental outcomes in babies. So for most of my moms, I'm cautioning them to sort of stop cannabis even while they're trying to get pregnant. Because I think some people say like, oh, I'll stop when I'm pregnant, but you don't know exactly the day you're going to get pregnant. Yeah. So it's better to kind of taper down. And cannabis actually can be very addictive and people can have pretty severe withdrawal, anxiety, insomnia, low appetite. So preparing for that is helpful.
What would you say to a pregnant person who is worried about their mental health in terms of seeking help, considering medication? What do you wish more pregnant people knew?
I wish they knew the risks and benefits of medication and their illness, which really only they know. So I think getting access to a mental health evaluation by a psychiatrist or a primary care physician that can spend enough time to get the psychiatric history is really important. So just like with pregnancy and fertility in general, I really wish women had access to education about the risks and benefits of mental health disorders in pregnancy and then the medications. And if they don't yet have that, seeking out a mental health professional to make sure they're aware and they're not learning off of TikTok or just what their friends do, and really learning, what does the established research say about their medications? Because a lot of times family members or even partners are really well-meaning and they'll say like, oh, just of course you have to stop your medications. But they don't know that this woman might have had suicidal thoughts 10 years ago and that this medication has been keeping those suicidal feelings at bay. Only she really knows. So each woman, I think, owes it to herself to get education, but also to get a professional's perspective before they decide to either stop medication or stay on medication. So they're making a really informed decision for them and for their baby.
What are some signs and symptoms people can look for in themselves or in a loved one that would alert us that something is going on that needs help?
So the most basic one is just not feeling like themselves. And I say that because it's broad and that's intentional. That's sort of such a sign that something's going wrong or different. But in the postpartum period, or even while women are pregnant, all of a sudden not being able to sleep. Now there's discomfort physically, but feeling so, we call it wired tired. So in the postpartum, women will be like anxious and, but exhausted and not sleeping, but then they try to sleep and they can't. That is a very common symptom of postpartum depression. So not being able to sleep even though you're exhausted is a symptom. Having these intrusive thoughts that we've kind of talked about, images that you're not wanting to have, but kind of coming into your head, or intrusive thoughts or intrusive images. Certainly, abnormal or psychotic thoughts, meaning I should hurt myself or I should hurt my baby. Obviously, those are concerning as well. And changes in appetite, even all of a sudden not being able to eat and, feed yourself. And therefore, if you're breastfeeding, not your baby, any distinct change in oneself is worthy of at least asking the question, is this normal or not, to a professional?
And it's tricky, right? Because when with 3 babies, your self-care and showering ritual changes after you have a baby. We've all done put the baby in the car seat and take a shower so you can watch the baby, or in the bouncer or whatever, or sit on the toilet with your baby because you can't put them down because they're crying and you need to pee. So there are distinct differences in sleep and the way that you're eating and your hygiene that can sort of be confusing, and thinking like, what, isn't everyone like this? Like, I haven't taken a shower for 3 days. Like, isn't everyone, so there's so many confounders with depression, anxiety, and with the postpartum period in the best of scenarios. I'm wondering if you can speak a little bit. I have 2 more questions. Question number 1, what has been your experience in working with people with eating disorders when it comes to perinatal psychology in general and the relationship with food in the pregnancy and the postpartum period?
So the perinatal period can certainly be a trigger for eating disorders, especially when women hear that you should gain 25 to 35 pounds for a healthy pregnancy. So, and there's a lot of guilt that comes out. Eating disorders can be hard to treat and sometimes never fully go away. So, for example, a patient of mine who's 55 and has been in remission for anorexia for 30 years, she still knows the calorie count on every single food she eats. So those relics can be there, and often they flare during pregnancy when someone needs to gain weight. So just being aware that that's almost common, and women can, again, seek help professionally if they're finding that to happen. And then I think that comes out in the postpartum too, when women want to lose the weight immediately. And there's this cultural conversation where people all of a sudden look not pregnant, or, even use surrogacy so that their bodies, don't actually change. So I think the cultural norms around what it's like to look like after you've had a baby are difficult.
I had a guest on the podcast a couple of months ago, Sarah Sheely, who is a certified nurse midwife and certified menopause practitioner. She's moved from birth to now the perimenopause and menopausal period. And she is involved in a practice where she looks very much at something called postpartum depletion syndrome and how it relates to the perimenopausal and menopausal period. And it turns out that when women are not, it's no surprise, but are not cared for during the postpartum period, physically, emotionally, mentally, in terms of nutrients and minerals that they need to be getting, those people actually have much worse outcomes in their menopausal period too. And I know that you have a private practice. So in our last few minutes, can you talk to me a little bit about what you're seeing in terms of similarities with your clients who are suffering with extreme mood changes in the perimenopausal and menopausal period, and if there's any correlation with their postpartum period?
So we absolutely see a correlation between hormones and mood, especially starting at menstruation. So a lot of women end up having their first episode of depression, and then maybe every month when they have their period, they have depression or anxiety that's pretty severe, even PMDD, premenstrual dysphoric disorder. And what that means is that the hormonal fluctuations that all of us have as women, there's varying responses from the brain. And some women don't have any mood shifts for their hormonal changes. And some women have really severe mood shifts. So for example, I've had women who feel suicidal for a week every month just because of hormones. And there's nothing wrong with them or their brains. It's just that their brains are much more sensitive hormonally. And so when we see these hormonal shifts in pregnancy, the postpartum, perimenopause, and menopause, those are often the same women who had those mood changes when they first got their period, when they were 13 and through every period after. So I say that all because women can try to be educated and think, okay, did I have a rough time with my period or peripartum? And if so, my hormones will, because they do for all of us, change during perimenopause and menopause. And I should be a little prepared about mood changes and get help early on when I need it.
Wow. I loved every second of being pregnant. I always joke, I could have been pregnant for 3 years, honestly. For me, pregnancy was like the summit of the best I've ever felt until I give birth. And that 24 hours afterwards, I fall so hard from the summit that like I'm on the floor from being, a million miles up in the air. So for sure, I can definitely see how that would be, that sensitivity to the hormones and even things like MTHFR and at the gene level, what our body is doing with those changes in proteins is there's so much more to learn, right? And I could have you here every single day and we would have a lot to talk about. And I'm so grateful for this hour with you. Thank you for being my guest. Tell my guests where they can find you.
So I can be found either on thompsonpsychiatry.com, which is my private practice, or remedypsychiatry.com. And all of our social media handles are on the footer of both of those websites.
You're amazing. Thank you for being my guest.
Thanks, Atoosa.